Hello and welcome back. So, one of the common tests which we come across in our day-to-day activities is antibody screening. So, once an antibody screening is positive, then we need to proceed for the antibody identification. So, identifying an antibody present in the serum is very important because in case this antibody is clinically significant, we need to select an antigen negative unit and transfuse the same unit to the patient. Else, it can cause an hemolytic transfusion reaction. It can also cause HTN in case of pregnancies. So we need to be very meticulous while selecting the units and the corresponding antigen negative units. So today we will be discussing, depending upon a case history, as to how do we proceed with identification of the antibody. What are the rules for ruling in or ruling out antibodies against certain specific antigens? And how do we conclude and confirm that, yes, this is the antibody which the patient has? So Dr. Shafina is here with me and she will show you how to proceed with the techniques and the methods. Thank you.
This is a case of 48-year-old male patient with a history of road traffic accident 2 months back and 2 units PRC transfused at that time. Now we received sample for the blood group and screening. His blood group is ORH positive and antibody screen came to be positive. So today I will be demonstrating how to perform the antibody screening and identification using the column agglutination technology using the commercially prepared reagent red cells. I have taken Bio-Rad's ID diacetyl 3-cell panel. Cells are checked for color change, hemolysis, batch number, lot number, expiry, etc. This is the patient serum to be tested. For antibody screening using the commercially prepared reagent cells, we had to follow the manufacturer's instruction. So, for using the Bio-Rad cells, we have to add 50 microliter of the red cell to the AG card. So we are using the Bio-Rad's AG card. So here we can see we have added the cell 1 and cell 2 now to the cell 3. Next step is the addition of 25 microliter of patient serum to all the wells. So here we can see we are adding 25 microliter to cell 1, cell 2 and cell 3. Next is incubation at 37 degrees Celsius for 15 minutes. After incubation, centrifuge the cards for 10 minutes. So this is the result we obtained after 10 minutes of centrifugation. So here we can see cell 1 there is a 3 plus reaction. In cell 2 and cell 3 it's negative. Now we have taken one corresponding antigram. This is the Bio-Rad's antigram for that cells we used and we have marked the results we obtained. We know the results are interpreted as positive or negative according to the presence or absence of reactivity. And in the antigram, suppose an antigen is present on the red cell and the serum is not reacting with it, the presence of the corresponding antibody can be excluded or ruled out or crossed out on the antigram. And also, we should consider the dosage effect of antigens, so it should not be ruled out on panel cells with heterozygous expression. In this antigram, we can see there is a reaction in first cell, but no reaction in the second and third cell. So, the patient serum has an antibody that is reacting to one of the antigen in first cell, but that antigen is absent in the second and third cell. So cross out the antigen that is not giving a reaction. So in crossing out, if an antigen is in homozygous expression, we can double cross, or if that antigen is in heterozygous expression, then only single cross. Here in this antigram, second and third cell has no reaction, so we can start crossing out. Second cell, The XG antigen, which is in homozygous expression, so double cross. Lutheran, double cross. Similarly, in second cell, all of them are in homozygous expression, so we can cross it out. Then in the third cell, we can see only the KIT is in hetero expression, so we can cross out by single cross. Rest all are in the homozygous expression, so double cross. After crossing out, the probable antibodies in patient serum can be KEL, KPA, and JKA. Once the antibody screening is positive, we have to proceed with the additional steps to identify the antibody. So the antibody identification panel must be of at least 10 cells and it should be done along with autocontrol. And if the autocontrol is positive, we have to proceed with that. Other prerequisites for antibody identification: a proper medical history, age and sex of patient, medical diagnosis, previous transfusion history. If the patient is a female, history of pregnancy or abortion, drug history like RHAG, daratumab or other antibodies, and also if any laboratory investigation reports are there, we should collect that also. For the antibody identification, here we have taken the Bio-Rad's panel cells, 11 cells. So 50 microliter of the reagent red cells should be added to the corresponding wells of the AG cuts. So all cells are added to the AG cuts. Now patient serum. 25 microliter of patient serum should be added to each well. Then incubation at 37 degrees Celsius for 15 minutes. Then centrifuge for 10 minutes after incubation. So this is the result we obtained after centrifugation. So here we can see there is no reaction in first cell. Second, there is a reaction. Third, fourth, no reaction. Fifth, no reaction. Sixth, there is a 3+ reaction. Now in 7, 8, 9, 10th and 11, there is no reaction. Now to the antigram, we mark the reaction. So there is 3+ reaction in the second cell and there is a 3+ reaction in the sixth cell. As we discussed before, we proceeded with crossing out. Now we can see, except KEL, all other antigens are ruled out and KEL is showing the pattern of reaction. We reported patient has anti-KEL antibody in his plasma, so that appropriate antigen KEL negative AG compatible PRC can be provided to the patient.
So my first question is, how important is history taking in cases of antibody screening and identification, and what importance does it hold? Like in this case, the patient was transfused 2 months ago. So in case he was transfused 4 or 5 months back, then what extra you would have done in this case?
Whenever an antibody is identified, it is confirmed by phenotyping the recipient cells. That is, the corresponding antigen will be negative in the recipient. But when the patient is recently sensitized, the transfused red cells will be there in the circulation and that can interfere the phenotyping.
So yes, phenotyping of the patient is also important while confirming the presence of an antibody, provided that the transfusion or any other sensitizing event was prior to 3 months. So my next question is, what are the antibodies which show dosage phenomena?
Yes. So dosage describes the expression of an antigen on the red cell. Double dose expression is when the gene is homozygous for that antigen, whereas if the gene is heterozygous, that is single dose expression. And the dosage is shown by RH, Lutheran, MNS, Duffy, and KIT.
So can you name the antigens whose expression is affected by the effect of enzymes? Because this knowledge is important when you're dealing with a case of multiple alloantibodies, and it will help in resolving these cases.
Enzymes can modify the red cell surface, and this modification can sometimes destroy certain antigens or sometimes it can enhance certain antigens. The RH, KIT, Lewis, P, I, and ABO are the antigens that will get enhanced, whereas the MNS, Duffy, and XG can get inactivated.
So what are the rules which help in ruling in and ruling out any alloantibody?
Yes. So one rule is using the Fisher-Exact method. That is, 3 antigen positive red cells are reactive, whereas 3 antigen negative cells are non-reactive. This indicates the specificity of the antibody identified. Another rule is using the Harris-Hogman method. So where this allows the minimum requirement for a probability. So when there is 2 reactive and 3 non-reactive, or when there is 1 reactive or 1 reactive with 7 non-reactive, this gives the minimum probability of identifying one antibody.
So thank you, and that's all for today. In the subsequent episodes, we will be covering up cases of multiple alloantibodies and how to differentiate between them. Till then, if you have any questions for the identification of a single alloantibody, you may drop into the comment sections. Thank you.